Alrighty, we're gonna get started. This is going over a neurophenomenological based examination of the psychotomimetic model of psychedelics. And we'll get into exactly what that means. So first of all, why are we focusing on this? Well, in recent years, psychedelic psychiatry has become quite a rapidly growing field. There are a number of different ongoing clinical trials for things like psilocybin-assisted therapy, treating a number of conditions, including depression, end-of-life anxiety, OCD, even Alzheimer's. And psilocybin, of course, is the active component in magic mushrooms. When we say psychedelics, we mean magic mushrooms, LSD, ayahuasca as well. And aside from just being a novel area of therapy, the FDA is also quite impressed with the results they're seeing, and they recently granted psilocybin for treatment-resistant depression breakthrough therapy status, meaning that it is on the fast track for approval. However, we simultaneously hear this long history of psychedelics being thought of something that mimics psychosis. There's a picture over there from 1955, where some of the first clinical trials or research trials with LSD thought of it from this perspective. And this seems like such a contradiction to us because it's therapeutic, it's helping a lot of people, or at least that's what the preliminary clinical trial results are showing. Yet, as a psychotomimetic, it's temporarily inducing a state similar to psychosis. And this, of course, would lead to clinicians, pending the FDA's approval, being wary to prescribe psilocybin, even in a very safe setting. And also, there is a lot of discussion about psychedelics potentially inducing psychosis, and that may likely be due to this, in part due to this history of it being considered a psychotomimetic. So I decided to take, as psilocybin and other psychedelics become more prevalent in the mainstream community, I decided to take a more thorough examination of this by reviewing schizophrenia and psychedelic-induced states, their phenomenology, as well as their neural correlates. And I looked at hallucinations, delusions, as well as resting state, fMRI, focusing specifically on the default mode network, as well as some graph theory-based approaches. Today, we're just going to have time to talk about delusions and the activity within the default mode network, but I believe that's the most important part. But just very briefly, the hallucinations in schizophrenia versus the psychedelic state tend to be very different. Schizophrenia, they tend to be auditory hallucinations, whereas with psychedelics, you get things like audiovisual synesthesia, etc. Very different. But today, we're just going to be focusing on delusions and the default mode network and how those two things are related. So in schizophrenia, what are the delusions like? The most prevalent ones are persecutory delusions. So thinking that people are out to get you. Could be that people are like whispering about you, things like that. And then the second most common is delusions of reference. So thinking like a newscaster is talking to you. And kind of the core phenomenology of this, according to some analysis, is that people with schizophrenia experience kind of a hyper-reflexivity and an increased self-referentialism. So things become about them that otherwise shouldn't be. And then in psychedelic states, although it's not often discussed as a delusion, really the core phenomena can be described as delusions. And this would be mostly ego dissolution, sometimes kind of termed as a mystical experience. But what ego dissolution really is it can be broken down as oceanic boundlessness, which is a sense of merger of self into the environment, and then also this phenomena of decreased self-referential processing, so feeling like there is no longer an I as a point of reference. And then going back to the neuroscience of this, the default mode network is the central resting state network in the brain. It includes the medial prefrontal cortex in the anterior and the posterior cingulate cortex in the posterior. And it's believed to support self-referential thought, introspection, and self-projection. And it's related to the concept of ego and self. So if a disorder and a state that the primary disruptions are that breakdown of a sense of self, we can see why it would be a valid area of inquiry to examine this network. So, looking at the default mode network in schizophrenia and its correlation to symptoms, the most prevalent finding through several reviews is that it's hyperconnected. So meaning that the nodes talk to each other more. And this is found using a variety of different analysis methods. So independent component analysis, seed-based, some other ones as well. And it's found in both medicated and unmedicated patients, which is a huge problem in schizophrenia research because people are on medication chronically, and that likely has an impact on their neural functioning. And it's also found in people before they actually develop schizophrenia. It's found in high-risk youth as well, who are showing some of the prodromal symptoms and also the family history. And the severity of the hyperconnectivity correlates to positive symptoms. So those positive symptoms being in part those delusions that we mentioned earlier. In psychedelic states, we see a decrease of within-network connectivity, so hypoconnectivity. And you can see with this picture from this study here, you can see how much the anterior and the posterior ends of the default mode network are talking to each other. After psilocybin, it decreases quite a bit. And ayahuasca also causes a decrease in activity in the default mode network overall, but it's not the network, it's not connectivity, it's decreases in specific areas within the default mode network, so a little different, likely due to some different pharmacology. And then the strength, again, of this default mode network dissolution is directly related to the symptoms and the phenomenology. With the greater default mode network decreases, the greater experience of ego dissolution. So in conclusion, based on the differences in phenomenology of the breakdown of the self, with everything becoming about you or you merging into the environment, as well as the neurology, the default mode network becoming hyperconnected or the default mode network becoming less connected, we can see that psychedelics and schizophrenia are not really all that similar. I would not say that psychedelic-induced states serve as a heuristically meaningful model of psychosis. However, there are some considerations. There aren't very many psychedelic studies. There needs to be quite a bit more to make substantial claims about what their basis in the brain is, and there's also potential sampling biases in participants. People who volunteer for these studies might have prior experience with psychedelics, or they might be more likely to take risk. And there's also other brain measures I did not account for, such as MEG and EEG. Simply did not have time to get into that. And there's other brain regions as well, such as the salience network, that are implicated in both disorders. However, the default mode network is so relevant to the concept of self, and since we see that's a core phenomena of both disorders, I chose to focus on that. But despite these caveats, it's pretty clear that there are some pretty significant differences in the brain. So going forward, what would I like to see with this? I would like to, instead of just reviewing studies, I would like to do a direct comparison of resting state connectivity within the default mode network using existing data, likely a seed-based study. And then I would like to also further compare psychedelic states to other psychotomimetics, such as stimulants. These are associated with an earlier onset of psychosis, actually, even when used as prescribed. And then ketamine, a dissociative, not a psychedelic, when given to healthy volunteers, induces positive and negative symptoms when these people were given a questionnaire. And I want to kind of account for why are these potentially better psychotomimics than psychedelics. And then I also want to re-examine this contraindication hypothesis, because based on the psychedelic state and schizophrenia being so different in the brain, I'm curious to see really whether the whole idea of psychedelic-induced states precipitating the onslaught of psychosis symptoms is really that significant of a concern compared to things like stimulants, which are already widely prescribed and not frequently talked about as being a contraindication for people with a family history of psychosis. And I believe that this is an important area of consideration because as psychedelics become widely used in the medical community, there are going to be people with depression who have a family history of psychosis, and they're not going to be able to receive treatment because of this. And I think that it's a worthy area to delve more deeply into that, using both neurological comparisons as well as epidemiology. So that is it. I want to thank everybody for coming and listening, and especially with writing my thesis, Dr. Turner was really helpful. She read over a lot of reviews. Atlanta, the local psychedelic society, really kind of encouraged me to do a lot of research in this topic, as well as Moshe Jacobson, who's in psychedelics. Atlanta, he was helpful for reading over drafts as well. And that is all, folks.